Hi, today I will talk in depth about the best treatment for epilepsy. I will tell you about the diagnosis of epilepsy, the investigations needed for epilepsy, and how we best treat it to stop the seizures, and even in the hardest cases where the patient is resistant to treatment. And I will tell you all about the new treatment for epilepsy that are really promising for the future, and even the things that are not even available yet and under investigations and research. So it will be a very in-depth discussion and will answer all your questions. So I'm Dr. Omar Dannoun, an epilepsy specialized neurologist. So first, tell me where you are talking to us, watching us from. So hey, Nicole, welcome. Hello, Jeannie, and Ramani is having questions. So definitely let me know where you're watching us from, which country, which state, and then tell me your questions, and definitely I will be answering them. I am from Asma, India. Welcome. From Hungary, EU. Welcome, everyone. From Arizona, excellent. That's warmer than Michigan, where I am. Greetings in Tennessee. Welcome, Tennessee. Welcome from Swansea. Excellent. Wow, Nigeria. Welcome from India. Welcome, everyone. Thank you so much for joining. It will be in-depth discussion. So let's first talk about epilepsy diagnosis. The most important step when we are talking about epilepsy is to nail the diagnosis, which means get the diagnosis right, because that is the most important step. Because if we do not get the diagnosis right, maybe we're chasing the wrong thing. So the way we make the diagnosis of epilepsy is first to get a comprehensive evaluation by a neurologist. The best doctor to treat epilepsy is a neurologist, the brain doctor who is specialized in treatment of brain disorders. We don't recommend like neurosurgeons or psychiatrists, but neurologist is the best one to treat epilepsy. And then we start with the clinical description. The most important thing in epilepsy, it is a clinical diagnosis, which means that epilepsy is diagnosed clinically in patients who talk to the doctor. The description of the events, how it happens from the beginning to the end, what the patient felt before, during the seizure, and after the seizure. And the best thing you can do is to take a video. I know that, when somebody is seizing in front of you, you might not be in the mood to take videos, but that is the most important information that helps the diagnosis of your epilepsy or your loved one's epilepsy. So having a video is very, very, very important. Netherlands, in India, Colorado, excellent. Thank you, everyone. Welcome. So what testing we need to do to diagnose epilepsy? The most important test is the brainwave test called EEG, or electroencephalogram. So electroencephalogram, we put wires on the head and we study the electricity in the brain to see what is the source of electricity, where is it coming from, what type, and so on. So we can diagnose epilepsy type, so if it's focal epilepsy or generalized epilepsy, based on the EEG. And the EEG can be negative, which means normal, and does not rule out the possibility of seizures and epilepsy. Here's some information about the EEG. The EEG is a test that tests the brain waves. So sometimes these abnormal waves do not happen during the EEG test. The way to get it higher and higher chances is to get a longer EEG, 30 to 60 minutes. Also, to have a patient sleep during the EEG. When you sleep, the brain calms down, so the abnormal electricity will be seen much better during sleep. So it is very, very important to have the patient sleep during their EEG, so that it will be more chances of detecting abnormal activity. And then if the initial EEG is normal, we can do either repeat ones, or we can do one that is longer, 24 hours. So that is a way to capture abnormal activity, even if the first EEG was normal. And yes, you can have epilepsy with EEG is normal, and all testing is normal. The other thing about EEG is that it is very, very important to know who read the EEG, because the EEG is as good as the one who reads it. EEG does not give you, for example, just a number like 5, 10. It is not like a blood level number. It is a test that is brainwaves, and then you read it, and then you interpret, like say, okay, this looks normal, this looks abnormal. So it comes down a lot to the experience of the doctor who reads the EEG to tell if this is normal or abnormal. The other test that we can do is brain MRI. So MRI is very, very important because it helps to tell what the brain structure is. So EEG will tell you the electricity and the brain waves, the activity, and the MRI will tell you the structure of the brain. So in patient brain MRI will show the structure of the brain, if the cells are forming right, if there is any scars, any abnormal cell formation, any tumor, anything, any infections, anything that can cause the seizures, abnormal blood vessels, bleeding, all these things can be causing seizures. So it's very important to do these tests. And then there are some specialized testing that we can do in other patients. For example, we can do blood work to make sure that electrolytes are normal, liver function, kidney function, also to get a baseline if we start a new medicine that can be kind of titrated and adjusted based on the function of the kidneys and the liver. And the other thing we do to evaluate epilepsy is to do, maybe in some selected cases, genetic testing, especially in pediatric and children, if we are looking at the syndrome of epilepsy. And then the treatment for epilepsy. So once we made the diagnosis, we have confirmed the diagnosis based on the symptoms and the testing, and then we're comfortable with that, then we go to the treatment. The most important pillar of treatment is the medical management, medical treatment of epilepsy. We start with medications that are called anti-seizure medications. These medications will lower the electricity in the brain and will control this excess electricity and have the area of the brain calm down and does not cause seizures. So the goal of this treatment is to calm down the electricity and stop seizures from happening. Some treatments, or like most of the medication, will not be able to take out the origin of the seizures. For example, like it will not go to the scar and take it out, and will not take out these abnormal cell formation, but it will calm them down so that they do not cause epileptic seizures. So that is the goal of the treatment. And then the choice of medication is very, very important. So some people ask, like, what is the best medicine for me? So here's the thing. In my clinic, I do not start two patients on the same medication, or two patients do not have the same prescription from me. What we do is that we individualize highly the patient's treatment based on their background, medical background, psychological background, physical, everything. And we try to choose the best medicine for them based on their epilepsy type and so on. For example, if we have a patient with generalized epilepsy, this is a specific epilepsy type, absent seizures, jerks all over, that is generalized epilepsy, will be diagnosed with EEG and so on. That epilepsy is unique and does not respond to many anti-seizure medications. In fact, some anti-seizure medication designed for focal epilepsy can make generalized epilepsy worse. So imagine you're taking a medicine for seizures and it's making your seizures worse. So that's important to know what type of epilepsy you have to be able to correctly treat it and choose the best medicine. And then we try to give a medicine that treats more than one condition. For example, if somebody has like psychiatric disorder, depression, anxiety, mood changes, anger, we avoid giving them levetiracetam or Keppra because that will cause depression and anxiety and anger and all of that. We give them medicine that can help that, can help their mood, which is like lamotrigine or Lamictal. So it's kind of, these are examples of treatments that we individualize the treatment plan. So the more individualized the plan, the better. And then the other thing is the length of treatment. So how long we need to treat patients for. So the treatment length is very, very, very important. And it is something that I see a lot in my patient clinic and also in my international consultations that I do with many patients outside the United States. I see a problem in that specific. Patients will start treating the seizures and then they will go for a year or two with no seizures and they will stop the medicine, and that will lead to recurrence of seizures, and that can be a problem. So our goal is to control the seizures on the long term. Our understanding of epilepsy, especially if it starts after the age of 12, is that it is a chronic condition and can last for life, like diabetes, hypertension. You can control it and treat it, but there is no cure so far for epilepsy, and then you need to treat for longer time. The treatment for epilepsy is not 2 years, and that is wrong information now. So treatment of epilepsy is not 2 years. It needs a longer treatment, and it can be lifelong. It depends on the type of epilepsy and where is it coming from and so on. So we tend to give longer time of treatment rather than just 2 years. That treatment can be drug resistant. So here are some statistics that you can put in mind when we are treating epilepsy. The first medicine is the most successful one in many patients. Patients will respond to their treatment in about 50 to 70%. Seizures will stop on the first medication, and that is the best outcome of treatment. And then if the first medication fails to control the seizures, then we can go to the second medication, and the chances of the second medication to stop the seizures can drop precipitously to about 15%. So that is a very low percentage. And then if two medications fails to control the seizures, then we go to the third medicine and afterwards, and that chances will be 1 to 5%. So very low chances And this is because the epilepsy itself is resistant to treatment. We call drug-resistant epilepsy. And that type of epilepsy, it needs more in-depth treatments and diagnostics and so on. So I will tell you more about how we approach this. The way we approach drug-resistant epilepsy and how we deal with it is to make sure we do a video EEG, inpatient video EEG. We admit the patient to the hospital. We do long-term video EEG for multiple days, day or 2 or 3 or longer. And then we record the actual seizures. We sometimes stop the medicine. We'll do photic stimulation, all these things to trigger seizures. And then we see the brain waves during the seizure. Is it epilepsy, or patient has psychogenic seizures, or the patient has physiological events like heart-related issues. There are multiple things can look like seizures, but they're not. So we make sure we diagnose the type of epilepsy. Is it focal or generalized? And then if it is focal, where is it happening in the brain, in one spot or more than that? And then once we do that, then we can do other investigations like MRI, mapping of the brain activity, to see if we can do surgical treatment. The other treatments we can do for epilepsy is the treatment with ketogenic diet. So ketogenic diet is an important treatment that can be used to treat epilepsy and seizures, especially in kids, because we give them the food we eat. Utilized patient will take lots of fat and proteins and low carbohydrate, and that will put the body into a state of ketosis, starvation, and then start breaking down fats and utilizing keto body ketones. And these ketones will make the blood and brain acidic environment, and that will lead to improvement in seizures. That happens. A few things about ketogenic diet. It is something with side effects. It can happen, can be heavy on the stomach and on the body. It can stunt the growth in kids, can cause kidney stones, can cause bad breath. So there are lots of side effects to that. And you should know that keto diet is a treatment for epilepsy, and you should never have like cheating days or sudden stop, because that will get you out of ketosis and can cause seizures to happen. And then the second thing, we do epilepsy surgery. So epilepsy surgery is a very successful treatment for seizures in certain patients where if there is a scar or the seizure happened from one area, we can take it out surgically. The new treatment, since we're talking about new things now, is the laser ablation. So we can do treatment with laser. So I'll show you this laser treatment. So this is the laser, and I did myself participate in studies and clinical trials for laser ablation. And this laser ablation, what it does, it will burn the area of the brain. Instead of taking it out surgically, then we do a laser ablation and try to stop it. So this is another example of, like, we put in the laser in the temporal lobe here, on the left and the right side, and then we burn that area instead of cutting through the skull and the brain to reach there. So that's how laser ablation works, and it can work in also like tumors and other things. So the philosophy is that instead of coming into the brain and cutting through the brain to reach that area that we need to take out, especially if it's deep area, we put in the laser, and the laser will do the surgery for us. So it's not like the cosmetic laser. You sit down under the laser, it will give you the healing rays. No, that's not like that. It's just that it causes burning of the brain in that area to help treat the seizures. So it has to be like a patient needs to be doing surgery, and then the laser will help. The other treatment is vagus nerve stimulation. So this is a surgery as well. We implant, if the seizures happen from multiple areas of the brain, not just one, we cannot take it out surgically. Or if the seizures happen and we don't know where it is coming from, or we cannot do resection, then we can do this vagus nerve stimulation device. This is the device. It is implanted in the chest under the clavicle on the left side, and then the wire will go on the vagus nerve inside the neck, and it will deliver electricity to the brain and help to treat seizures. So vagus nerve can be a helpful device. They're all devices considered palliative devices, which means that they will help with the seizures, but the chances of them stopping the seizures completely are low, between 5 to 15%. But it does help a lot with seizure frequency, intensity, and also the recovery after the seizure will be shorter with this device. So it is worth considering. The other device is deep brain stimulation. So deep brain stimulation is very, very important device also that can be done. So this is the device. We put in the wires inside the brain, and the wires will be threaded out, and then the device will go in the chest, the same as vagus nerve. It's kind of battery that gives electricity stimulation to the brain and helps with seizure treatment. And then the other thing that we can do for this is responsive neurostimulation, or RNS device. So RNS device is really a unique device. This is how the device looks like. It's a small device that is implanted in the skull, and then there is a wire or a strip that is put inside the brain, and then it will read the brain activity. So this device, will read the brain activity all the time, and when it sees a seizure, it will deliver electricity shock to stop the seizure and treat it. And the good thing about this device is that it records the brain waves all the time, so we will know for sure if the patient had a seizure or not, because many patients, about more than 50% of them, will not know for sure if they have a seizure or not. So because the seizure, remember, it happens in the memory area of the brain. So if you have a seizure, then it's busy with the seizure, so will not write the memory. So unless somebody tells you that you have a seizure, sometimes you don't know. So this can be a reason. And another treatment that I really want to talk to you about this is this new medicine called cenobamate. So cenobamate is a medication that it's a new, relatively was FDA approved in November 2019, and then we honestly, like myself included, had a hesitancy about this medicine because it does have interaction with other medications and it does have a rare allergic reaction. However, when I saw many doctors use it as well, I started using it, and it has very, very, very high success rate, much better than all the other anti-seizure medications. So we start using that medicine early on, and for patients who are resistant to treatment, and I have patients even canceled surgery because of cenobamate. So it's very, very important medicine. We should definitely consider it in any patient who is resistant to treatment, especially in adults, and they tried multiple medications. So cenobamate can be a good alternative to the treatment. Hopefully it can control the seizures, but there are some cases that do not respond to cenobamate and we need to do surgery. So cenobamate is a medicine that is titratable, so we need to start very slow to prevent this allergic reaction. We go 12.5 for 2 weeks once a day, and then 25 for once a day for 2 weeks, and then 50 for once a day for 2 weeks, and then 100 milligram once a day afterwards, and then the maximum dose is 400 milligrams. So this is how we use cenobamate. It does interact with other medications, so we need to, especially medications work on sodium channels like lacosamide, Vimpat, or phenytoin, or Tegretol, carbamazepine, or oxcarbazepine. All these medications need to be lowered a little bit so that it gives the room for the medicine to work and be tolerated. And then, so kind of like, I'll just give you my conscious, my policy in this channel is to never get any sponsorship or anything from pharma companies or device companies or anyone who makes treatment for epilepsy, so that I will tell you my own conscious and own professional opinion. So future treatments of epilepsy, this is a very important thing, like look into the future, the crystal ball now. So we have a future treatment for epilepsy, and I myself participate in multiple of these clinical trials that are bringing new treatments to the market to hopefully have better cures and better treatments for epilepsy. And the first one that I would really like to tell you about, it's going to happen in the future in about a year or two. It's called azetukalner, which it's called from Xenon Pharmaceutical. This medicine is a unique medication, works on potassium channels. Like all the traditional medications for epilepsy work on sodium channels, work on calcium, work on receptors, NMDA, GABA, all of these things. But we have this, the only medicine that works on potassium channel. Only one medicine before that was done. It's called potassium Potiga, and it was withdrawn from market in 2017 because it was causing people to have a skin reaction. It turns them blue, but this medicine does not cause that. Does not cause blue person syndrome or Smurfs syndrome. Does not do that. So it's a good medicine, and then it helps to treat the seizures. And the good thing about this medicine, the seizure freedom rate is good so far in the clinical trials, and it is a once-a-day medicine and does not have any serious adverse events, and it is an antidepressant, which is, I'm excited about that. It helps depression and anxiety, so that is a big plus with this medication. And then the other exciting, really exciting treatment, which I'm involved in studying, is the stem cell therapy for epilepsy. So stem cell therapy is that we implant stem cells that are mature, and then they go into that state of producing, they call interneurons. They are producing GABA, which is the inhibition in the brain. So kind of like we implant firefighters to fight the fire in the brain. So this is the treatment. So implant these stem cells in the temporal lobe now, one side or both sides, and then they will start doing the job of the medicine, which is calming down the electricity in the brain and producing GABA. And at the first year, you need to take anti-immune suppressants, like immune suppressant medication, to stop the immune system from attacking these new seeds, new treatment cells. And then usually we will stop it afterwards. And then hopefully on the long term, they will treat the brain inside. So that's kind of the closest to a cure. The other treatment is genetic therapy. So gene therapy is also an important and promising treatment for epilepsy, especially if there is a problem in the genes. For example, in Dravet syndrome, we have a new gene therapy. It's not like called gene therapy because it's kind of gene modulation. So they do not go and change the genes inside the body, but what they do, they will change the expression of these genes. It's called mRNA, ASO and mRNA. So these mRNA is what they do. The small molecules that will block the prescription, the bad genes from working, and then they will give the chance for the normal genes to work, and that will really help seizures. And it's being done for multiple other things other than just Dravet syndrome. So this is a promising treatment. I'm keeping an eye on all of these, so make sure to subscribe to this channel to get all the latest and greatest information about epilepsy treatment. And then to kind of like know exactly what type of treatment that works for you, I started this consultation. So you can get direct consultation with me. You can book your appointment. I have the link in the description of this video and all the videos on the channels. You can book your appointment today, and we can get one-on-one consultation that we can do via video. I did consultation all over the world, from Australia, New Zealand, India, Middle East, Europe, everywhere. Like I did consultation that was very helpful. Every patient who had the consultation was life-changing, and then was very, very helpful for them. And definitely I'm very happy to see people like really have a good response to their treatment. And now to the best part of this video, which is your questions. I would like to interact with you directly and answer all your questions. So make sure you write a question once, and then I will definitely get to all the questions. So I'm going all the way back to the questions and start answering them one by one. So Ramani said, I have a simple partial seizures. What medicine is best, have the least side effects? So yes, so that's a very important question. So the patient has a simple partial seizure. Now we call focal seizures, and then the latest nomenclature, the naming of seizures, has just been released last week. And now it's called focal impaired consciousness or focal intact consciousness. So that's also something that is new. So how we treat the patients, as we said at the beginning, that we choose the best medicine for the patient. We try to study the patient's background, the medical background, psychological background, medical history, liver function, kidney function, all of these, and the type of epilepsy together, all put them together to choose the best medicine. The style of like Keppra for everybody, that's wrong, because Keppra is not the best medicine for everybody, and it all does have psychiatric side effects. So we have to choose the best medicine. Overall, the newer medications have less side effects. Overall, the efficacy, like how strong the medicine on seizures, is almost the same in all of them, but the side effect profile is less with newer medications. Okay. Is PNES and catamenial epilepsy exist together? So what PNES is psychogenic non-epileptic seizures. This is a type of it's called psychogenic, which is called like a functionological disorder. There is dissociation between the brain and the body, and that can lead to seizures and shaking. And this is overall a psychological condition, not epilepsy. And then the other one is called catamenial epilepsy. So catamenial epilepsy is a specific condition of epilepsy when there is exacerbation and more seizures during the menstrual period. And I did a video about PNES, like there is a whole series about PNES you can watch, and about catamenial epilepsy, like how we treat both. Can they coexist? Yes. They can coexist. Well, two things. Are we sure for sure that the patient has epilepsy and it is catamenial epilepsy? That's number one, like proven with EEG that they have epilepsy. That's number one. And then, or there is just like stress around the period can cause PNES to happen. So that's important to know the diagnosis, and the way to know the diagnosis, have long-term video EEG. Can epilepsy and PNES happen? The answer is yes. They can happen together. About 10% can have both epilepsy and non-epileptic seizures. My child recently diagnosed with occipital epilepsy. He is only 5 years old. Is it curable? So, as we said, in children, when they are young, they can have what we call benign epilepsy syndrome. So benign epilepsy syndrome is that the brain is developing in children especially, and then once they grow, they will outgrow their epilepsy, which means that the brain is dependent on like chloride and potassium early on in life, and calcium, and then when they grow, they will go to the mature and the adult brain, and these will change, and then the epilepsy will go away with it. So occipital epilepsy is most of the cases called Baniatopoulos, and other one which is called Gastaut. Both of them are one of the benign ones, which means that sometimes we don't even treat them. Sometimes we treat them for a short period of time, and then it will be it will outgrow it. So it's kind of individualized, but yeah, it can be something that can go away with time. Okay, perfect. Keep going with your questions. I'm just going on them one by one. I'm becoming a patient at Barrow Neurological Institute. I'm rare, complex, and need 72-hour EEG. Yes, yes, Arizona Barrow. I have my friends there, one of my teachers there. So yes, so they can have epilepsy. And then the best way to approach anybody with epilepsy is to do long-term video EEG, and to do that is the best way to kind of approach it. So you need to prove, as we said, do you have epilepsy or non-epileptic together, and this is the best way to approach it. To start with long-term video EEG, so they are doing the right thing. Yeah, my son have idiopathic epilepsy. That is right. We know for sure that not everybody with epilepsy, we know what the cause. About 50%, we don't know the cause. We do EEG will be normal, MRI will be normal, and we call it idiopathic epilepsy. Idiopathic means a fancy word, means we don't know. Idio means we don't know. Pathic means what's the cause. I have vertigo. Yes, it can happen. Okay. Yeah, anyone experience euphoria? Sometimes my seizure can be helpful, not feeling pain. Yeah, well, all kind of feelings can happen with seizures, and euphoria can be really like one of them. Okay, and then there are some people talking to each other. Okay, so I had my surgery a few months ago on the left side, and now I don't have seizures anymore after 11 years. Okay, well, that's great. So, well, thank you for sharing, Siri, your experience. That is great. Congratulations. We should do a few things. First of all, like you went all the way to surgery. You have done surgery, and seizures were not controlled for 12 years. So that's good that you have surgery. And make sure to continue the treatment and medications, because if you stop your medications, like celebrate too early, then the network that was opened by the surgery will click back and seizures will happen back. So very, very important to not stop the medications, because that will cause seizures to happen back. So it's very, very important to continue the treatment, especially the medication that we're working. And then lots of people congratulating you, Siri. That's great. Thank you so much for sharing your. Could epilepsy have developed on a person after being vaccinated for COVID? That is an important question. Can COVID vaccine cause epilepsy? There, so far, we have not had any evidence that people who were vaccinated for COVID-19 have higher rates of epilepsy than anyone else. And I don't see like a mechanism how the vaccine that is like in the body and in the blood will cause epilepsy in the brain. So I don't think that vaccination by itself can cause epilepsy, and there is no evidence to that. So vaccine should be safe in people with epilepsy and should not cause epilepsy. My doctor prescribed brivaracetam. Okay, excellent. So brivaracetam is a medicine for seizures. It's the second generation of levetiracetam, or Keppra. So brivaracetam is called Briviact, and this is second generation. It has less psychiatric side effects. Some people argue that has a little bit of efficacy better. So definitely, I have a whole video on brivaracetam. I will recommend you watch it, and that can be helpful. I have normal focal epilepsy EEG, normal brain MRI, still having breakthrough seizures every couple of months. All doctors are doing is putting tablet strength up, 1600 eslicarbazepine and 200 brivaracetam. What can I ask the doctor to do next? Excellent. Very, very important, Elias. So this is what we do. If we try 2 medications and seizures continue to happen, and especially probably you're being treated by a community neurologist that is not epilepsy specialist, is to refer you. So ask your doctor to refer you to the epilepsy center, or you go yourself to the epilepsy center. So you can go to epilepsy, just search in Google, epilepsy center near me. There is Epilepsy Foundation have all, and National Epilepsy Centers. They will have a map of all the epilepsy centers in the United States, and around you, if you're outside the United States, go to the nearest epilepsy center. Then they will need to do a video EEG, long-term video EEG. Then they will see like what type of epilepsy you have, where is it coming from, you have epilepsy or not, all of that. So it's kind of like this is the in-depth approach. Just having seizures, increase medication, it's a vicious cycle. So we don't do that. We go to the root cause and try to understand the epilepsy better, and the best way to do it through an epilepsy center. So make sure, ask your doctor to go to an epilepsy center. Very good. I have the RNS, and I am on 2 seizures medication. All still have absent seizures, not as many as I used to, but still have some. Yeah, so as I said, in the RNS, it will not stop the seizures completely in many patients. About the success rate of stopping seizures 100% will be about 10 to 20% with RNS. It helps with time, and it can decrease the seizure frequency and the seizure intensity. But yes, there are some people who still have seizures despite being on RNS device and medications. And these patients, we try to use cenobamate, the new medicine. If they're already on it, then try to other medications that hopefully can help. I will say my doctor I talked to said it could maybe have an effect taking COVID shots. Well, in my opinion, we don't have evidence that COVID shots can cause epilepsy. I rely on evidence and studies rather than just personal opinion. I apparently had a congenital defect and I had an extra tissue hanging out of my brain, but I don't know why they have not seen it ever on MRI in 11 years. See you. Why? Okay, such a thing only now. Yes. So here's the thing. We said that in MRI we have a epilepsy protocol MRI, and the one who reads the MRI, their experience matters. Maybe you're talking about what we call encephalocele. That's hanging from the brain. So in the temporal lobes, there will be like a defect in the skull, and that temporal lobe leads a little cleft, and then the brain hangs from there, and that is called encephalocele. Maybe that's your code. I'm not sure about you, but this can be like something that we can see in patients. Duncan Ramsey, yes, I recognize your name. You're always here, so thank you so much for showing up. I've gone from having 30 to 60-second grand mal seizures twice a week to having 10 to 20 seconds, 5 to 7 times a year. So that's a huge improvement. Post it a couple of days, but now I'm immediately come back. Yeah, so see, like there is a huge improvement. So instead of having like many seizures, long, big seizures, now they're shorter, they're less frequent and less intense. So that is a success of the treatment. Sometimes seizure freedom might not be like the achievable, but we can at least decrease the intensity, decrease the frequency and the burden from the seizures. My seizures happened three times. First 2014, 2022, and then 2025. Yeah, why? So, why the seizures happen? This one question. We have many causes of seizures and epilepsy. It can be structure, it can be cells not forming right, and so on. And then the second thing about the timing of seizures. So this is what happens, the behavior of epilepsy. At the beginning, it's a network that is digging its path inside the brain. So for example, I think of it as like a river of water that is digging its path. So once it is established, that's it. It's going to become stronger. So that's what your experience. We had seizure 2014, and then way later, like 8 years later, you had another seizure. And then the second seizure did not wait for 8 years. It did only 3 years. And that's, what is worrisome in here is that the seizure frequency and like the time between seizures is shrinking. That means the seizure is getting stronger and stronger, this seed that is implanted, and then it can be frequent in the future and cause seizures to happen more. So it's better if you have diagnosis of epilepsy, better to be in treatment so that you don't have stronger seizures. Question, Shiny, I'm told by my consultant that there is no point identifying triggers as the goal is to stop the seizures. If this is the focus, how do they know what they are treating? If you're talking about triggers for seizures, it's very important to identify triggers for seizures because that will trigger seizures. So if you have a trigger for your seizure that you know for sure, you should avoid it because that will help to not have more seizures in the future. So that is an important thing to do. Definitely avoiding the triggers will lower the chances of having seizures coming back. Okay, my seizures happen twice. Yes, we answered this question. Yeah, you don't need to repeat the questions because I'm getting through all the comments and the questions one by one. So I might get like to it later, but you don't need to repeat them. Okay. Some people just repeated the question. So I have focal seizures from either first or second strokes. Yes, that's right. So strokes will cause a scar in the brain and disturbance in the brain structure, and that scar can cause seizures in the future. It can be like usually about 6 months to a year after the stroke is done to start having seizures, and most of them can respond well to treatment, but some of them can be resistant. Okay, just keep going with there are lots of discussions on their own. I got an MRI saying that I have MV and T. Now it seems that I'm starting to replace Keppra with lamotrigine. My complex partials are improving. Are there chances to I get surgery slimmer? Okay. So MV and T, maybe this is like a multifocal or periventricular heterotropias. Let's see what MV and T like in this situation. MV and T. Multinodal voculating neuronal tumor. Okay, so this is a type of MVNT. It's kind of a neuronal tumor. So sometimes it's a good news that you have a cause for your seizures that you can attack it with surgically and excise it, and that can be the curative procedure to help with seizures. So not necessarily that the chances are slimmer, is that you have a reason why seizures happen, then you can take it out surgically. Okay. Is livable 100 livable is levetiracetam, Keppra, and clonazepam, which with folic acid 5 milligram is good first month pregnancy and epilepsy. Okay, so multiple questions here. Livable in epilepsy and folic acid. So here's what we do for patients who are pregnant. Levetiracetam overall is one of the safest anti-seizure medications for during pregnancy. That's great. It does change during pregnancy because the body starts to secrete more fluids and all of that, and then it will change the processing and will secrete it. So we have to always monitor the levels and increase the medicine over time so it does not cause seizures from that. Second one, clobazam. So clobazam is not the safest medication in pregnancy. It is not very safe. So it's a decision individualized. I cannot make a decision for you to take it or not, but this is not of the safest medications. Folic acid. So folic acid also is something that there is a controversy in the literature, like among doctors, of what is the best dose to give. We give in the United States 1 milligrams only if somebody has history of neurotrope defects before we give 4 milligrams. 5 milligrams might be too high of a dose because there's some evidence now recently that high doses of this medicine might not be a very good thing, like folic acid. So folic acid is helpful, but high doses are not very good. Okay. Okay, why? Okay, so lots of discussions with Suri. Okay, so my son developed epilepsy right after taking Johnson & Johnson COVID vaccine. Yeah, so here's the thing. So it's hard to say that. Yeah, we don't want to discuss this like for too long, but it's hard to say that if somebody, like there are billions of people vaccinated, and then also thousands or millions of people have epilepsy. If two things happen together, does not mean that one caused the other. Like if you're driving and then you're texting and then so it's kind of like hard to say like one caused the other. So this is like a case report does not you cannot draw conclusions. Other lefties are high as well. Okay, so lots of discussions among people. Okay, anybody had post-ictal psychosis? Okay, so post-ictal psychosis can happen, and we have cases of that. Myself, even I saw patients, and my patients with post-ictal psychosis. What happens? The patient have a seizure. Right after the seizure, will be in this psychotic state of confusion, agitation, paranoia, all of that. And it happens more in the temporal lobe epilepsy, and it can last for 1 to 2 days, and some people have lasted for longer than that and even weeks. Any thoughts on perampanel? I'm starting this medication soon. Excellent. Yeah. So perampanel, from the name, is works on AMPA receptor, perampanel. So it's one of the unique mechanism of seizures stopping. So it's a good medicine, helps with seizures. It's an oral medication. It is given once a day. The side effect that we should know of is that it can cause psychiatric side effects. So if you have depression, anxiety, PTSD, anger, mood changes, you should not be taking perampanel because it can exacerbate these psychiatric disorders. But if you never had any psychiatric issues before, then perampanel might be a good option. And then it works for focal and generalized epilepsy. And the other thing with the perampanel, it has this unique side effects called homicidal ideation. You have like ideas of killing others. But overall, it's a good medicine. The psychiatric side effects, we found that it starts in age and milligrams. 2 to 4 are safe. 6 and above, they are psychiatric disorders start. I had no seizures after 2 years, but now I have issues with my liver. Yes, as I said, that some medications will affect the liver, the kidneys, and so on. So if there is a liver medication that affects the liver, you should better to like switch it to something else that your doctor to not affect the liver. Okay, so many doctors told me that since the brain damage is in the sensory strip, in the parietal lobe, isn't an option. Would laser ablation be an option? Yes. So laser ablation, as I said, is a technique that we are deciding to do surgery already. There is a scar in the brain and we need to do surgery. But instead of opening the skull, we just do it through a laser. That's it. It's not like a treatment by itself. It's destructive to the brain, but it is a surgery that we do instead of opening the skull, we do surgery. So if the scar is in the sensory strip, means like if you take it out, then you will be have sensory loss, and maybe you can even have weakness. Then you cannot do the surgery. So by the same time, you cannot do laser. What we do in these situations, we call functional cortex or eloquent cortex, where the seizures start. Then we can do what we call focal stimulation, like responsive neurostimulation. It can be a helpful thing. So ask your doctor about that. Okay, excellent. So this is a comment from Suhaib from LinkedIn. Thank you. So we're streaming on LinkedIn, on YouTube, and on Facebook. This is definitely a wonderful session. Thank you for aspiring neurologists. Thank you so much, Suhaib, and good luck. If you want to be a neurologist, then be my colleague, and excellent. So stay in touch if you need any help with being a neurologist. Okay, can a 10-year-old with Douce syndrome take Xcopri is an epilim and lamotrigine? Okay, excellent. So the question, so I cannot make recommendations or medical judgment or any advice to an individual patient or somebody. But what I can say in general information, cenobamate Xcopri is a medicine approved for 18 years and older. So we need to give it only for that age. However, now it is being studied for children. So I know my colleagues in pediatrics, they are studying it in children. So definitely we will know the safety in children soon. So they're studying it from 12 years old and older. So that's good. And then maybe we can also, like in the future, go into lower. But for now, it is only available in adults, 18 years old and older. Can epilepsy patient do marriage? Why not? Seizures can be caused because of hormonal imbalances. Okay. Can epilepsy patient get married? Of course, 100%. Congratulations, go get married, no problem from that. So marriage by itself should not be a problem. I had a whole video about marriage and epilepsy. What few recommendations and comments for males and females, for women and men, when you go get married, make sure that your partner know that you have epilepsy. If you're a man going to propose to a woman, or you're a woman and then somebody's coming to you, tell them that you have epilepsy and be open about it from the beginning. Do not hide it, because it will show up later in the future. So be open about it from the beginning. Also, you can get the neurologist involved to tell them that, like here, my neurologist can explain to you what is epilepsy and the treatment. So be open, tell them from the beginning. You can get your neurologist involved in how to break things to the partner. And then the second thing about pregnancy, it can be done in epilepsy, but we should know the medication effect. There is a whole video about the pregnancy and epilepsy. I have all medications, what is percentage of affecting the baby, all of that. In span, this is like this. So I cannot, there is just, I cannot read, unfortunately, Rana, from French, so I will need translation. Okay, are GABA supplements such to help seizures? No, there are no supplements that can treat seizures, unfortunately, as a treatment, so I don't recommend that. Taking zonisamide led to having post-ictal psychosis after prodrome not identified such. It's not some medication. I'm not sure if the zonisamide by itself is the cause of post-ictal psychosis, but it can happen either way. I'm interested in gene stem cell therapy. Yes, definitely. We are studying that. Hopefully in the near future, that will be out. So we're studying the stem cell therapy, and the gene therapy is coming. So these things are really important. And then this is very, very good. Dr. Insha Sahur, welcome. Thank you, Dr. Danoon. Very informative session. Thank you so much for attending. And I really like to see people even on LinkedIn, they're watching us. So that's very, very nice. What is the best for nocturnal seizures? Nocturnal seizures are seizures that happen during sleep, and they are treated like any other seizure. It depends on the type, focal seizure or generalized epilepsy or focal epilepsy. There are some medication that works on the sodium channels work better, like lacosamide or carbamazepine, but this is not a rule for everybody. I'm taking Breviact, lacosamide, clobazam. I'm seizure from 2 years. I'm very happy. That's good. Congratulations that you have no seizures. That's very good. So do not stop medicine, because that is why the seizures stop. Okay, my daughter have progressive myoclonic epilepsy and caused by genetic mutation. Yes, DNM1I. Have you had patients with diagnosis that she's 6 years old? Yes, I do have some patients with progressive myoclonic epilepsy. This happens, like, I'm an adult provider. I see 16 years and older, but pediatric neurologists see more of these syndromes. But yes, so progressive myoclonic epilepsy is a type of epilepsy that is progressive. It gets worse with time. There is some issue with the brain formation and electricity that cause seizures, causes developmental issues, and also causes decay in the brain function. Unfortunately, there are some studies, and it can cause multiple causes. All of them are genetic, and unfortunately, the function gets worse with time. We control the seizures, but sometimes the brain function decay can get worse with time. And we're investigating gene therapies for these, but it is a long way to go. I suddenly lost consciousness. What kind of seizures I have? My doctor prescribed Brivirestim. Okay, so I cannot tell like somebody's seizures, but seizures can lead to loss of consciousness. Somebody will, sometimes it's kind of a series of events, but you don't remember them because no one saw you. That kind of stops and move and then shake and then afterward lose consciousness. So the type of epilepsy depends on the seizure, but also on the EEG findings. Is livable clobazam safe in first trimester? Yes, we answered that. What is the latest treatment for tuberous sclerosis related refractory epilepsy? Thanks. Excellent. Vinod asked about this. So it's a very good question. So tuberous sclerosis complex it's a genetic condition that affects the protein production in the brain, and that will lead to tumors, which are like hard, tough things happens in the brain, and they cause seizures. And it can cause also, like, it's a systematic condition that causes heart issues, lung issues, kidney, all of these things. So that is tuberous sclerosis. There are some mTOR inhibitors like everolimus and rapamycin. These medications are specific for tuberous sclerosis. They are very good. And if somebody has refractory epilepsy, we try to go over these tubers and dissect them, especially if we know what is the tuber that is causing the seizure. I'm taking medications regularly, but my seizures are still not controlled. What is the reason behind that? Yes, this is likely a type of epilepsy we call refractory epilepsy or drug-resistant epilepsy. This type of seizures, the seizures will continue despite being on medications. And this is the type that I'm saying that we need to go to the epilepsy center, investigate them for surgery, because that is the best way to treat these kinds of seizures. Okay, so please tell about how neurologists taper medication, which criteria doctor reduce medication. So I will direct you to the video I made on YouTube. It's called how to stop anti-seizure medication or stopping weaning anti-seizure medication. In this video, I explain in depth what are the criteria, how we can make it happen. But overall, we don't recommend to stop seizure medication. But if the doctor wants to stop it, it should be like slow taper down and make sure that there is no like abnormal electricity in the brain or scars or seizures of your heart. So it's kind of very individualized decision. We can like make a consultation and sit down together and decide together if we can do it or not, but definitely not good like to do it for everyone. I've been experiencing absent seizures where I was told present but unresponsive. I'm on generic Kipra and went from 500 to 750. How would I know that escalation dose help? So first of all, like if you don't know that you're having the seizure, then we can do that to admit the patient to the hospital and do long-term EEG for like 1 day, 2 days, 3 days, to just see if the treatment is successful or not. And I have done that to my patients. So you can ask your doctor if that can help you or not. Okay. more than 5 months have passed since my last epileptic seizure, November, at that upon Dr. Sigdem's recommendation, treatment of Revita was initiated along with Keppra. Okay, so that's good that no more seizures are happening. What is the best treatment for Lennox-Gastaut syndrome, LGS? So I think Lennox-Gastaut is one of the most difficult epilepsy syndromes. It does cause seizures to be like multiple different types of seizures, and it can be the most resistant. There are treatments like the vagus nerve stimulation can help, other medications can help, but honestly, it is one of the most resistant types to treatment. Like every medication you put in, the chances of stopping seizure is very low. My seizure was last month. I still have headaches on left side of my head. My memory is not anymore. I'm Keppra and nothing works for my headaches. Yes. So some people have headache disorder and epilepsy together. They can happen together. So some medication, we need to treat the headache itself and to treat the seizures. Now there are multiple new medications for headache that you can take to help with seizures. We have answer this question. You don't need to do multiple questions, like to repeat the questions. I will just answer. What's your opinion about Fycompa? We talked about this perampanel, so you can just go back a little bit and to the live, and I answered that question. My kid is 6-year-old and taking lamotrigine, Frisium, chlorogram, HIT, and very good. Yeah, so multiple medications. I hope that the seizures are controlled, but if not, then you can ask about other treatments like surgical treatment. What is the name of the episode that have one leg shaking, then you fall, and then so lose consciousness? So this is like focal to bilateral tonic-clonic seizure. So focal starts in one leg, shakes, and then the electricity marches in the brain. It's called Jacksonian march. This Dr. Healing Jackson described it in his wife. She was having seizure that moves her arm and then face and all over the body, and that's called Jacksonian march, or like marching seizures. My 6 months after brain tumor resection left insular low-grade glioma. My seizures suddenly increased, even though the MRI remains stable. Why this is? Yes. So I have a whole video on that. It's called brain tumor and epilepsy. When we do resection of the tumor, the scar behind it and the resection, especially if it was done also radiation or chemotherapy, the destruction of the brain tumor can leave out some material from the tumor that can irritate the brain around it and cause seizures to happen. So yes, it can happen. We increase the medicine until seizures calm down, and then we will drop the medications afterwards. Does surgery left temporal lobe have a negative effect on the vocabulary recall? Yes, this is called verbal memory. Yes, it can affect especially the temporal lobe on the left side. It's called the dominant temporal lobe, and it can have effect. But also, if you leave the seizures alone, then it can cause more destruction in that area and causes the verbal memory to go bad. I had brain surgery and then seizures still happen. Yes, unfortunately, brain surgery do not cure everybody. Sometimes the seizure network is large, and we resected some of it, but some is left, and we cannot take it. Okay, so Samina says, I take levetiracetam, lamotrigine. I have spike. I have waves and spikes on EEG. However, confusion while going anything that is quick, dancing type, confused, no other things. So maybe the confusion can be maybe from medications itself, because these medications can affect the balance rather than the epilepsy treatment. So is it a good idea to get genetic or what I believe is called a pharmacological test to have anti-seizure medication works best to prove from have seizures? So this is called pharmacogenetics, which means that we do a genetic testing to see what medication processed in the body. At this point, we don't have a good genetic test that can tell us which medicine the body will respond to well. There are some genetic testing will tell us the processing of medications, means like, the liver will process lamotrigine and like 50% and so on, but there's no genetic test right now can guide the treatment for seizures. Does auras stop with epilepsy medication? Yes, auras are epileptic seizures and should be treated as such, and they can be helped with that. Had anyone else have stroke and had epilepsy? Yes, of course. Lots of people have stroke and they have epilepsy as a consequence, 10 to 15% probably. Okay. Let's have more questions that were not asked multiple times. And then, hi doc, recommend 2 medications, one Lyris and 500, and second medication to pyramid. Tell me about these medications. So the medication, the effect, like I will recommend to go to the video that has explanation, like to pyramid. They have explanation. I have videos on every medication, and it can help. Can folic acid helps to reduce trigger for seizures? No, the folic acid does not help seizures itself, but it is very helpful for women of childbearing age, so that will prevent malformations from the anti-seizure medications. Okay. My daughter have epilepsy, take multiple medications. Please advise. So if the seizures continue, then you can ask about the surgery. Any new treatments for Givan syndrome? Yes. So Givan syndrome is a epilepsy, is generalized epilepsy that has seizures with eyelid myoclonia, and that can be causing the seizures. And then what we recommend in this is to have medications specifically for generalized epilepsy. Now, recently, the cenobamate medication is very helpful, and it can be treating generalized epilepsy. So far, it's being studied, but I think it's helpful. EMG, MRI does not find where the seizures, the rest like PET scan, MEG, and SPECT. Yes, this can be, all the testing together can help each other to provide where is it coming from. Some medication have been increased from chrono. Do I amend my diet? I don't understand the question. Like, is it like patient is on ketogenic diet or not? Then it's your recommendation individually. I cannot answer questions individually because this is your medical decision with the doctor. So you ask your doctor about that. Okay, there are lots of other questions that I really like the discussion. I'm on cenobamate. When I reached 200 milligram, my seizure stopped for 4 to 5 months, but then it started again, and every time I take higher dose, my seizure stop. My brain gets used to the cenobamate. It can be possible that it's called what we call honeymoon period, means that we give the medicine and the seizure stop a little bit with time, and then the seizure kind of finds a way to the network to strengthen again, and then cause seizures to happen afterwards. Yes, it can happen. Can anti-epileptic affect brain and memory of a person? Yes, I have a whole video about that. Anti-seizure medications and memory. You can review that. It helps you to understand. But yes, it can affect. Anti-seizure medication can cause effect on memory, but also epilepsy itself, especially uncontrolled seizures, can cause memory loss. Also, the anxiety and depression can cause memory loss. So there are multiple causes of memory loss in patients with epilepsy, not just the seizure. There's a whole video about that. You can watch it. Okay, so yeah, so there are lots of more questions. So definitely, I'm very happy to see this engagement, and definitely I will be sure to make more live streams like this and answer all your questions. And you can, if you want, you can always get a consultation directly with me, so we can go over your case and give you your individualized treatment and treatment plan that it can help you. And I have more videos that can explain epilepsy in depth and how to treat it. You can watch it in this video that has all treatment for epilepsy. And stay healthy, and see you in the next one. Salam.